Hello, good afternoon, everyone. Great seeing you all here in a new 2022 series of webinars on our collaboration between Iran Petcan and Young SciP. I would like to welcome you all on behalf of our webinar steering committee, which is me. I'm Roelof van Ewijk, one clinical fellow in pediatric oncology at the Prinses Maxima Institute in the Netherlands, and I, together with Teresa de Rojas, Sofia Castro, under supervision of Andisha Atabashi. And we very much look forward, after the success of last year, to continue this series and are very pleased of the contributions to the new young members and the experts of this year. And for today, I would like to introduce you Jimena de Pedro. She is currently an attending physician at the hospital, the Universitario de Cruces in Bilbao, in Spain. She has been working at the Biocruces Health Research Institute, and she completed some mentorship at the Great Ormond Street Hospital. She's focusing her oncology career on leukemias, lymphomas, brain tumors, and new drugs and clinical trials. And as such, she's a member of the Spanish Society of Pediatric Oncology. Very welcome to hear your case today, Jimena, which is supervised by our expert, Daniel Orbach. I think Daniel Orbach needs a little introduction, but he is a pediatrician specializing in oncology, and he's head of the Department of Pediatric, Adolescent and Young Adult Oncology at Institut Curie in Paris. He is an important member of the French-European groups working on rare diseases and soft tissue sarcomas, and one of the founding members of the Very Rare Childhood Cancer Group in France, Fracture, and also the European group of pediatricians taking care of these children with very rare cancers, the expert group. We are very welcome that Dr. Orbach, with his great career in translational clinical research, as our expert of today. And with that, I would like to give the word to Jimena for the introduction of the case.
Good afternoon. Thank you for the kind introduction and the opportunity to share and discuss this case. So, next slide. These are our disclosures. Next slide. I'm going to present the case of a little 7-month-old healthy male. His parents took him to the emergency room after noticing a lump in the right shoulder that same day. He had no relevant past medical history. Upon physical examination, he had a palpable hard mass in right deltoid region. Next slide. An MRI was done, which showed an heterogeneous solid mass developed in the deltoid muscle, with nodal axillar involvement. Next slide. This is our first question to the audience. Which tumor would you suspect? So it could be a rhabdomyosarcoma, synovial sarcoma, rhabdoid tumor, Ewing sarcoma, infantile fibrosarcoma. Okay, perfect. Okay, I'll continue with the case and okay, next slide. So a biopsy was done and the pathology report described a small blue round cell tumor on hematoxylin and eosin stained sections. Then immunohistochemistry demonstrated a diffuse CD99 expression. By FISH analysis, the tumor presented an EWSR1 rearrangement, and the pathology report concluded that the tumor was an Ewing sarcoma. Next slide. Tumor specimen was sent to another center for NGS, but couldn't be done due to technical problems. Next slide. A PET-CT and bilateral bone marrow aspirate and biopsy were done to complete the staging. The PET-CT described an elevated metabolic activity in the right deltoid mass and the ipsilateral axillar lymphadenopathy with a possible uptake in right ileum that thought to be reactive. The marrow showed no infiltration. The next slide. Our surgeons tried to do a biopsy of the axillary adenopathy without success, and the final diagnosis was of an Ewing sarcoma with regional lymph node involvement. We started treatment as the Ewing protocol 2012 RMB. After 3 cycles, a radiological assessment was done, showing a partial response with a reduction of more than 50% of the tumor volume. After completing the whole induction chemotherapy and before surgery, a PET-CT showed a complete metabolic response with stability of the tumor volume. The patient underwent surgery as per protocol, in the next slide, with a wide exeresis of the middle and posterior portions of the deltoid muscle. They tried to resect the axillary adenopathy but had disappeared. The medial border was affected and the percentage of necrosis was of 75% of the tumor specimen, according to the pathology report. With this poor response, we sent frozen tumor again for an NGS panel. He completed the consolidation chemotherapy with chemotherapy and radiotherapy. He received 45 grays plus a 54 gray boost on the tumor bed that included the axillary adenopathy. On the next slide. When he was about to finish the therapy, the NGS panel report came back with shocking news. There was no EWSR1 rearrangements found, and instead they found a biallelic SMARCB1 nonsense mutations that caused a loss of function of SMARCB1 protein in the tumor. So the second question for the audience: does this finding changes our original diagnosis? Yes, no, I don't know. Okay. Okay, perfect. Yes, I agree. And now the third and last question. Which tumor would you suspect now? Again, rhabdomyosarcoma, synovial sarcoma, rhabdoid tumor, an Ewing sarcoma, an infantile fibrosarcoma. Okay, yeah, I agree as well. So the next. So without going into too much detail, SMARCB1 gene is located in chromosome 22. It encodes for a protein that has multiple names, INI1, BAF47, and plays a role as a tumor suppressor gene. As I said, this biallelic mutation causes an inactivation of the gene and therefore no expression of the protein in the tumor. The loss of SMARCB1 staining by immunohistochemistry is the cornerstone of rhabdoid tumor diagnosis and other tumors, also called SMARCB1 deficient tumors. Next slide, which are all of these just to show. Next slide. The initial tumor specimen was revised, adding SMARCB1 stain, and showed loss of nuclear expression. The EWSR1 gene rearrangement by FISH analysis was repeated and not found, so apparently seemed a misinterpretation in the first place. The final diagnosis was changed to a rhabdoid tumor. The diagnosis was confirmed by the European Rhabdoid Registry. On the next slide. And next slide. Malignant rhabdoid tumors are a rare, highly aggressive embryonal neoplasm, most common in infancy and childhood, with a dismal prognosis. Some rhabdoid tumors are histologically indistinguishable from Ewing sarcoma, so the SMARCB1 stain is critical for diagnosis. There is a rhabdoid tumor predisposition syndrome, where about 1/3 of patients with these tumors present with germline mutations. This was also tested in our patient, but he didn't present any germline mutation. Next. The patient was, as I said, finishing chemotherapy when the change of diagnosis became clear. We, of course, had to inform the parents. And although the conversation was not easy, they were very understanding. At least we knew that although we had treated him with another protocol, there is no standard treatment for rhabdoid tumors. And all treatments are based on sarcoma-like protocols. Next slide. Unfortunately, our patient relapsed. And next slide, showing a single pulmonar nodule in inferior right lobe at the end of treatment. He underwent surgery and several pulmonar metastases were found. The next slide. We decided against chemotherapy. He received radiotherapy, a whole lung radiotherapy with 15 grays plus a boost of 54 grays on the tumor bed. And we started with tazemetostat, a new drug that is an EZH2 inhibitor. Despite the treatment, the tumor progressed and the patient passed away 3 months later. So now I leave you with Dr. Orbach expert discussion.
Thank you, Jimena, for the presentation. And I think just to recall what I put in the chat as well, that please, concerning the case, if there are any questions or open questions for the case or things unclear, please ask your question in the box and we'll answer your questions. As I'm waiting for the questions, I would like to invite Dr. Orbach with his view on this case and the diagnostic dilemma.
Thank you very much. Thank you very, Jimena. Just to stress 2-3 things, could I have the next slide? Here, it's an interesting question because, of course, there has a misdiagnosis. And I just put you this slide showing that every sarcoma occur in some period of age. So it's mean that, of course, you have not the same sarcomas in newborn, children, adolescent, young adult patient, and adults. So here there were 2 ATP, I think, to accept the diagnosis easily of Ewing sarcoma. Of course, the age, and as you know, Ewing sarcomas are more tumor from young children, adolescent, and young adults. So this was an ATP, and of course the nodal involvement, which is quite more unusual in Ewing sarcoma. Next one. So as you can see, if you have infant and newborn, you should evoke rhabdoid tumor, infertile sarcoma, of course, some rhabdom sarcoma, and some indifferent sarcoma. And of course, synovial sarcoma is more in older children. Next one. This is what is a very nice presentation who stress the fact that the biology is, for me, quite mandatory in the diagnosis of all sarcoma in Europe now. And of course, you remember that all techniques could be used to analyze and seek for already known fusion transcript. You can use FISH or RT-PCR if you know the diagnosis of the tumor and if you want to confirm the presence of the AWS sarcoma or another one. But of course, if you don't exactly know which type of transcript fusion you are looking at, you can do RNA sequencing on FFPE or fresh material. And with this new large technique, you could find, of course, every fusion transcript. And as it changes very rapidly, I'm really in favor to use RNA sequencing, which is not so expensive. It is the price of 3 FISH techniques. So nowadays, it's a very quite cheaper techniques. Next one. Oh, next one. And of course, RNA sequencing, I have put this slide to you to remember that we can find, of course, fusion transcript with RNA sequencing. We can find some information about mutation, and here you may find mutation on the INI1 deletion or mutation. you can have some prognosis signature with RNA sequencing, and you may have some clustering. So if you are not familiar with clustering, is the way to compare the biology of your tumor to a bibliothèque, a large panel of other tumor already annotated. So you put only your tumor in the cluster and say which comparison, which my tumor could compare to which one of other already known tumors. And of course, if it's close to rhabdoid tumor, you can say my tumor has the same biology of a rhabdoid one. And so it's a very nice way to try to define your tumor if you are not totally confident with the pathologic diagnosis. Next one. And the last thing I wanted to say is to speak about histology. I'm not pathologist, of course, but as you can see in such a tumor, there are some quite not so, but quite characteristic data to think about rhabdoid tumor. When you have a tumor, of course, occurring in young children, we have already said that, with large one cells tumor, it's eosinocytoplasm, huge nucleolysis and intracytoplasmic inclusion, as you can see here, and with a B phenotypic immunochemistry, vimentin and epithelial one. Of course, you should think about rhabdoid tumor. Next one. And as Jimena said, the most important one is the absence of any one immunostaining. So just remember that usually we have immunostaining which is positive for desmin, positive for EMEA, for keratin, for instance, in such a rhabdoid tumor who is B phenotypic, but in INI1 is a negative one, so it is the loss of the INI1 staining that could confirm the diagnosis of INI1 deficient tumor. And of course, in here, it's very evocated of a rhabdoid tumor. And on the right slide, you have here the vessels. The vessels are normal. They are coming from the children, so they are INI1 positive, so it's normal cells. But the tumor in blue with the arrow in are lost the INI1 immunostaining and appears blue and not brown after the INI1 antibodies. So this is important when you have an infant with sarcoma. It should be quite systematic to do an immunochemistry with INI1. Next one.
I think we can go to the previous one and then just take the take-home message a bit later, maybe discuss some of the questions from the audience. And I think one of the first questions raised, and I think that's a part of the treatment, maybe we can, is the question by Dr. Papian, and she asked whether you did see any clinical response, Jimena, to the tazemetostat?
No.
Yeah, no, he didn't present no any response. No, he continued progressing and no.
Just remember that tazemetostat, which is an EZH2 inhibitor, has not shown a very good response in soft part rhabdoid tumor. It seems to be a little bit more efficient in intracranial TRT tumors, but not in soft part primary. So nowadays we cannot consider this second line therapy as a standard here. Of course, it was good to try it, but the first data shows that this drug is not so efficient.
If I may reflect on the treatment, we had treated a patient for Ewing sarcoma, and then you explained about the comparison between the rhabdoid treatment currently. And Dr. Orbach, could you reflect on the current recommendations for upfront therapy in rhabdoid
There have been a lot of discussion. As Jimena said, there is no standard of therapy. And we have analyzed recently and published in the European Journal of Cancer the French experience and the European experience on VDCIE, so I mean the Ewing sarcoma protocol, which means a dose intensity chemotherapy every 2 weeks. And the results were quite similar than with the previous one, which the previous one in the EPSAG, European Pediatric Soft Tissue Sarcoma, was an alternative drug, just like in the RAB protocol. So what we can say is that this protocol and this treatment with VDC-IE is a good one. The tolerance was good, and in our experience in France, we have been able to give at least 90% of all the courses, and the efficacy was quite good, but not so exciting. We have nowadays a overall prognosis around 40% of survival in such a tumor.
Thank you. And then I've got another question by our colleague Adelema Silva, and she asked to Jimena, did you have any chance to rule out the rhabdoid tumor predisposition syndrome, or did you ever look at any tumor predisposition syndrome in this patient?
We looked for the germline mutation, but not other predisposition syndrome, and he didn't present the mutation. He had also an older sister that was healthy, and there were no other history in the family that made us think that.
Yes, that is important. 30%, as Jimena said, of the patient with rhabdoid tumor has a germline mutation, and this is more frequent if the patient is younger. So it's like 50-60% when the disease occur during the first year of age. So you should propose this, do the germline test. And of course, if the germline E1 mutation is absent, if there is no mutation, there is no other germline predisposition syndrome that you have to seek.
Thank you for that answer. And then a question by our colleague Evangelina Antonio, and she asked whether is there any data on high dose therapy followed by stem cell transplantation in rhabdoid tumors? Could that be an option or not as treatment?
You want me to answer, Jimena?
Okay.
Yes.
Thank you.
Yes. Now the question of the high dose chemotherapy after the induction chemotherapy and the question of maintenance therapy still remains, because there is no data on this, and we have no comparison data. We don't know exactly if it brings something good favorable for on the outcome. So it's a subject of debate, and we cannot say that you should do it or not. Some teams do it because are giving high dose chemotherapy, some not. For instance, in Curie, we prefer to give maintenance therapy with vinorelbine cyclo because it's less toxic than high dose chemotherapy and so on. But as you know, there is no comparative data. So you can see the thing in one way, saying it's a dangerous disease, important disease, so I want to give maximum of therapy, or you can say there is no proof that high dose chemotherapy brings improved survival, and so I prefer to give another thing. We prefer the last option, but it's not. It's our only expert opinion.
And in line with that expert opinion, may I ask, how do you foresee the upcoming years of interest and how the improvement of therapy will take place in Europe? Is there any further collaborative effort, or?
Nowadays, there are a lot of labs who works on this disease, and of course, we hope that target therapy will help to treat these patients. Tazemetostat was a little bit disappointed, as I said, but we have other HDAC inhibitor and so other tumors that may be included with chemotherapy, and the option for the next months, year, will be to give an association with target therapy and chemotherapy immediately if it's possible. But to be honest, we have not the right drug today, but we hope it will be the possibility in few years, and maybe it will be because some teams had a nice option to discuss, but it's not only preclinical data now.
Thank you so much. I think it might be time. I don't know others. Sorry, there's still an incoming question by our colleague Pedro Albert from Spain. She asked, what about anti-PD-1 or PD-L1 with standard chemotherapy? Would immunotherapy be an option in these patients? I think I would like to pose a question to Professor Orbach.
Yes, the immunotherapy. Now, we have had a case with a high burden of mutation in one tumor, who very nicely responds to immunotherapy. So we have been very excited by this. We have published this case and tried to give some immunotherapy, but it was a single case, and other patients who received immunotherapy were disappointed in terms of a tumor response. So nowadays, except in part in protocol, there is no place to give immunotherapy in such a tumor because it has not see a very nice efficacy. So only for today, only chemotherapy. Surgery, what is important in such a tumor is the early local therapy. I could stress that the fact that you should try to operate the tumor as soon as you can. And of course, radiotherapy may have a place, but of course, the problem is that patients are young, the tumor are large, the dose of chemotherapy are high. So it's of course an MTD discussion.
Thank you so much for your reflection on the case, Dr. Orbach. May I go to the take-home message and to you, Jimena?
Perfect. So these are our take-home messages to finish. We'll always reconsider the diagnosis in case of doubts. We had doubts from the beginning. Our patient was an infant. He had nodal involvement and a soft tissue mass, all of which are characteristic not commonly seen in Ewing sarcoma. It's very important to make sure that INI1 SMARCB1 staining is done in all infant sarcomas by the pathology department. Although in our case, the EWSR1 gene rearrangement was a misinterpretation, it's important to know that not all sarcomas with EWSR1 rearrangements are Ewing sarcomas. Nowadays, it's highly recommended to integrate molecular characterization in the diagnostic workup. And to finish, even though our patient was misdiagnosed, we are grateful that at least he was not mistreated. And so, well, thank you all for your attention, and I hope you've enjoyed the presentation.
I think we enjoyed your presentation and the discussion very much, and I would like to thank all the attendees for also putting their questions in, which makes this a highly interactive webinar and also gives us more in-depth on the difficulties in the treatment of these patients. And I would like to very much invite all the people to attend the upcoming webinars, which are in total 7 webinars this year. And you can register early already on the website. You receive the updates. And so we are happy to see the attendees here today and look forward to seeing you at our next ERA PETCAN Young SciP initiatives. And with that, I would like to thank you very much for your attention and see you at our next webinar. Thank you very much.
Thank you very much.
Thank you, Damien. Thank you.
Goodbye.